We have taken on this task of developing episodes. Governor Beebe, about a year and a half ago, almost 2 years ago now, decided that because we had a looming financial challenge to Medicaid, and that in general it is becoming extremely difficult to continue to raise premiums, to raise tax revenues, or to keep raising copays, that we had a real challenge on our hands for health care and health care delivery, and that perhaps it was time to rethink about how we pay for care, and that the current fee-for-service system tends to pay for services regardless of quality and outcome, and begin to shift our framework to rewarding outcomes and quality, or at least incentivize effective health care. So he challenged the Arkansas Medicaid program, Arkansas Blue Cross, a few other private payers. We've been in contact with Medicare as well to design a different way of doing business. The initial thoughts of doing bundling was quickly sent ice water through people's veins, in the sense that we really aren't prepared in our state, doctor to hospital, doctor to doctor, to really have discussions and to effectively look at how to share revenue. But instead we began to look at the notion of having accountable physicians manage episodes of care and put incentives in place for efficiency and quality. So that's what we've been doing for the last year and a half. We had our colleagues here from McKinsey join us in August of 2011. We had a blank piece of paper, and we got to work. We actually launched 5 episodes last July, about 5 months ago, on URI, working in developmental disabilities, heart failure, pregnancy, hip and knee surgery, and I've forgotten there's one other one I'm blanking on here. ADHD, that's right. And so now we're working on 3 new ones, plus oppositional defiant disorder, in a way of trying to bend the cost curve. So on the next slide, the framework is to head toward the triple aim that Berwick talked about, to improve the patient journey, to have efficient care, to improve the health of the population, and to manage unit costs over time. This is in the context of other activities going on in Arkansas that includes workforce development. How are we going to have the right mix of professionals for the future? How are we going to deal with the challenges if we have healthcare access improvements, especially in rural Arkansas? How do we get the care done? How do we integrate health information technology to make our healthcare system more effective? And then how do we also engage patients to be more accountable and take personal responsibility? So the overall framework is how do we improve our healthcare system by having the payers, the providers, and the patients all review what their roles in the healthcare system, change their behavior, so that we can have greater value for the resources we use to deliver products and services in healthcare. So at this point, I'm going to turn it over to David Greenwood to kind of go over other aspects of the payment improvement initiative.
Thank you, Bill. As Bill said, the Medicaid shortfall, funding shortfall, was looming. Healthcare costs in Arkansas reaching the point, as they are all across the country, affordability is a huge issue. So you have a number of options of things that you can do about that. One of the things that, and we need to put the next slide up, I'm sorry. One of the things that we have been doing is passing the cost on to the consumer through higher premiums or higher deductibles and copays. Another option you would have would just be to reduce the level of reimbursement that you pay to providers across the state. Another option is to intervene, have the payers intervene in the medical decisions through managed care. That was one of the options that we did not want to do. And you could also limit what you cover and reduce the amount of services that were covered. Or you can do what we've opted to do, what we're aiming to try to do to improve quality and control costs, and that's, as the slide indicates, transition to a payment system that rewards value and patient health outcomes by aligning financial incentives with quality. Next slide, please. The principles that we're operating underneath this is that the the programs needs to be patient-centered, that it needs to be focused on improving the quality and the quality of the patient experience, as well as trying to be more cost efficient. It should be clinically appropriate. That's part of the reason why we're having this meeting today and why we continue to look for input from providers across the state on all the episodes that we've been working on. It needs to be practical. As Bill pointed out, the bundling scenario was not practical. We've tried to implement something that we can manage the scope and complexity of, and you'll hear details about that later on in the evening. And then we want it to be data-based, and of course, that's our area at Blue Cross Blue Shield. We deal with data. We're trying to make design decisions based on facts and data, and working hard to do that. Next slide, please. In doing this, through the episodes that we've done already, we've tried to work closely with providers and patients across the state. We've interacted with 500 plus providers, patients, and family members, held 21 public work group meetings, including those connected as tonight through video conference. 23 months of research, data analysis, expert interview, infrastructure development. You'll hear the details of that as we go through it tonight, to design and launch these episode-based payments. And then monthly, we continue to meet with the Hospital Association, the Medical Association, and others to keep them informed on what we're doing and how the episode payment design is proceeding. The episode-based model is designed to reward coordinated, team-based high quality of care for specific conditions or procedures. So it's episode-based, it's not individual procedure-based, but we're trying to coordinate the care across the whole range of the patient's experience. And the goal being a coordinated team-based care for all services related to a specific condition, procedure, or disability. For example, the pregnancy episode includes all care prenatal through delivery. And then accountability. We're assigning what we call a quarterback, or a principal accountable provider, a PAP, is designated as the lead person across all pre-specified services across the episode. And the PAP is selected to be the provider in the best position to influence the quality and cost of care. And then the incentives are high quality, cost efficient care is rewarded beyond current reimbursement based on the PAP's average cost and total quality of care across each episode. And that's what we're going to spend quite a bit of time tonight, is talking and defining how this works and the various items that go into that. Next slide. Yeah, we're there. Okay. How episodes work for patients and providers. Patients receive and providers deliver care as they do today. Nothing much changes on the front end other than the fact that the patient goes to the provider provides the care, submits the claim exactly as you do today, paid under the same fee-for-service provisions that you're paid today, and the payers reimburse for those services exactly as they do today. The change comes after the fact. It's retrospective. We calculate incentive payments based on outcomes after the close of a 12-month performance period. So we take 12 months against 12 months of results against a predetermined threshold amount, and depending on how the average cost of a provider fits in that, there's the opportunity to be paid additional amounts. There's the opportunity to remain in the same financial shape that you were before, and there's an opportunity to share in the risk if your costs are high. And if you look at it under number 5, it shows a graph there that shows the variation in cost across the average cost across each episode for each one of the PAPs. We compare the average cost to predetermined commendable and acceptable levels, and we'll go through more detail on that. And as I said, based on the results, the providers either get additional payments, stay the same, or have some of the payments drawn back.
So yeah, as David said, let's go to the next slide. The key thing here is that Most folks are getting paid just as today. The fee-for-service happens just like today. You then, at the end of the year, the PAPs get arrayed by their average cost of care. So we don't expect every case to be the same. We certainly allow for biologic variation. We have some risk adjustments. We get rid of the major outliers. And at the end of the year, each one of these bars on this graph would represent potentially a individual provider of a service that's the same service across all the bars. So in this slide, you can see that you go from on the far left, you have the folks that are the highest cost per episode on average, not per episode, but not every episode itself, but on average. On the far right, you have the folks who are the lowest cost on average. And so you have different thresholds, and there's an acceptable threshold that would probably only account for, at this point, maybe 10 or 15% of the providers, and that is fixed in many ways. We'll talk about that in a minute. So the folks at the far left, when they go above the acceptable threshold, they are at risk for 50% of the average cost above that threshold. So if they are $400 on average above the acceptable threshold, they would be at risk for $200 per case, because that's their average cost, up to 10% of their total payer reimbursement for that payer. Now, if you go to further down, folks in between acceptable and commendable, those folks have done their services, gotten their fee for service over the year. Their average cost per episode is kind of in the middle somewhere, and so that's the end of the episode for them. They are not at risk. They don't have any bonuses. They're just sort of, if you will, it's over and done with for them for the year. Then you have folks that are between commendable and gain-sharing limit. These folks, if they pass quality metrics, have shown that they've been more effective or more efficient than many of their peers, and so they will share 50% of their average savings per case, up to a gain-sharing limit. So we've designed the episodes so that there is a minimum that we think that would be appropriate to be spent on the episode. So once you go below that, if for some reason you have figured out a way that you're below, on average, the gain-sharing limit, we will not give you additional sharing of the reduction in cost. So we want to make sure there's certain limits in terms of how low you would spend per case. And I'm not sure this would be an issue, or if there is, we'd want to study what you're doing, because either you're doing something unusual, or you're doing something we may want to learn about. And we, as I mentioned, we have some quality metrics. So in order to qualify for gain sharing, you would have to pass, go back one slide. Sorry about that. You would have to, we have some quality metrics. We're not expecting people, we have a pay for performance program in Medicaid. We're not expecting people to get an A-, B+ to qualify for gain sharing, but we do expect a B-, C+. We do want some demonstration that you're hitting some certain quality metrics. So we are not going to be gain sharing folks who, for whatever reason, are missing some core metrics. What's a core metric? Well, say, for example, in obstetrics, it's making sure that they have documentation that women delivering a child have been tested and screened for HIV, for example. There's no reason for babies to be born unexpectedly to an HIV-positive mother. We should at least be aware of what it is going into the delivery. We will do some that we have acquired passing, and we have some that we're going to expect just for tracking. And so this is a way we can build quality into the episodes as well as the effectiveness. Next slide. In July, with the first wave of episodes, we have given all the PAPs report cards. They are actually fairly in-depth. They're several pages long. They tell you whether you are at risk for gain sharing or risk sharing. It tells you where you are in terms of your quality metrics, and it also shows you where you are in regards to your peers. Gives you a lot of detail on each of your episodes, each of your patients, what was spent on those patients. Next slide. And this is also an interesting page out of the report card. It gives you a breakdown of about 8 or 9 elements of cost for your episodes and it compares how you did compared to your peers. So you can tell that if your peers had a similar distribution of patients, how you spent pharmacy dollars, how you spent x-ray dollars, how you spent ER dollars. And you could begin to see how you spent dollars compared to your peers. You could see the strengths or the relative strengths or weaknesses of your practice profile compared to that of your peers.